Thank you for coming. Happy Valentine's Day, anyway, to start. So, today, again, we have a great case.
You're okay.
We have a great case. Our presenter is on his way, stuck in traffic. Hopefully, he will be here, but anyway, we can start showing the slides. So, the presenter will be Dr. Yildiz. He's Advanced Cardiac Imaging Fellow in Mount Sinai West. We have a great panel. Dr. Miller, who's Associate Professor and with Cardiac Electrophysiology. Dr. Elis Huami, who is Associate Professor with CT Surgery. Dr. Trivieri, hopefully she will join by phone. She had some problems with school for her kids. Associate Professor and does a lot of trials here and also a trial regarding this topic that we'll talk today. And also Dr. Agorwal, Associate Professor from Mount Sinai Morningside. So good morning and hope you will enjoy the conference. And I know this topic was discussed on ground rounds 2 weeks ago by Dr. Miller, but I think repetition is good and we'll show some great images and some great movies. So and, the moderator will be Dr. Hadley. I will be here, and I think we can start.
Pass it around as needed.
Good morning, everyone. As Dr. Larakis said, we're waiting on our presenter stuck in traffic. These are not my slides, but we will do our best. So let's dive into the case. So we've got a 73-year-old female patient who presented a couple years ago with shortness of breath on exertion, some palpitations. Otherwise, fairly unremarkable medical history, some hypertension, diverticulosis. She was a prior smoker, but quit over 20 years ago. Minimal alcohol use, no significant surgical history. Right now, just on Toprol XL25, which I think was prescribed for the hypertension initially, and then 325 aspirin. On exam, again, nothing particularly remarkable except for a 3 out of 6 systolic murmur. Lab's pretty unremarkable as well, BNP mildly elevated. And here is her EKG. Dr. Miller, can you tell us what you see?
Hear me? So obviously it's a 12-lead EKG. There's 2 different PVCs there. The dominant PVC looks like a left bundle in V1 and a positive fluorescent inferior lead, so it's an outflow tract PVC. Or at least in the outflow tract area, I should say. And the second PVC, which is I guess the third to last beat on the EKG, looks like right bundle with a superior axis, which suggests it's going to be papillary muscle origin, probably posteromedial papillary muscle. So one outflow tract PVC, which is the dominant, and then a second rare PVC, which is the papillary muscle.
Terrific. Chest X-ray. Anything remarkable from our panelists here? Nothing really jumps out. Okay.
I'll take the pulmonary vasculature is okay. Lungs look all right. Good breath. Thin person.
So she gets an initial echo. Could we have maybe Dr. Agorwal or Dr. Larakis discuss what they see here?
Yeah, I mean, so it's parasternal long axis view. You can see that the posterior leaflet is prolapsing. And basically, it has to be like 2 millimeters, the leaflet 2 millimeters below the matrilineus line. And also have associated moderate MR at least, you can see. So that's about it. I mean, I don't know if you can show most likely other images that will show the matrilineal disjunction better.
Right.
And again, this is severe mitral regurgitation. And for the fellows, the way to see mitral valve prolapse and to call it is only the parasternal long axis or the 3-chamber apical view, but you should not call like a 4-chamber view or other views mitral prolapse.
So Stan, posterior leaflet prolapse, should you expect the jet to be more anterior or why is more central?
Yeah, you will expect it to be more anterior, but
I think here, that the fulcrum isn't too sharp because you have mitral annular calcification. And that's why I think that Dr. Lorakis was struggling with, is there mitral annular disjunction? Because the mitral annular calcification sort of limits that mobility. And therefore, so this may be a partial flail, so you don't get to see the full flipping of the leaflet. So therefore, it's only sort of partial. So I think the mitral annular calcification plays a role, and also the annulus is sort of heaped up more than you normally would see it, right? So anatomically, this is not like the typical younger person with prolapse.
It's not being directed solely by a prolapse mechanism.
So to look more at these mechanisms, the patient gets a transesophageal echo. I'll come back to this tissue Doppler in a second. Anything to add here?
Better view of the prolapse, I guess. Better view of the prolapse of the posterior leaflet. And again, this was not done here, so.
Right. Those of us who have rotated with our structural echo attendings know we have a very specific protocol for going through this. And then this is more of a bicommissural view, an attempt at it.
Yes, so this is most likely the P2 scallop that is prolapsing.
So Dr. Elishmawi, as you think about surgical planning, what in these images are you looking for? What's helpful?
I mean, it seems to be like a bit of an advanced stage of prolapse because you can see the mitral annular calcification, but there is plenty of tissue on both leaflet, particularly the posterior leaflet. So this valve in reference center should be almost 100% repairable if you have an indication for which you said the patient has symptoms. So.
Right. Here's a 3D image again from this outside hospital TEE.
Yeah, basically this is not how we do it, but the aorta is on the right, it should be on the top. So you can see the prolapse of the P2 scallop. Here it's with the mitral regurgitation on the right. So this view should be rotated to have the aorta on the 12 o'clock, and you will see the posterior leaflet with the P2 scallop prolapsing.
Great. And then they quantified this using PISA, which we all learn as fellows, and comes out to moderate to severe MR, I think, in terms of volume and the EROA. And again, not my slides, but this is sort of the natural history of mitral prolapse. You know, you have an initial genetic predisposition, then you get this sort of hammocking of the valve, which moves to prolapse when you've got more 2 millimeters behind the mitral annular plane, and then mitral regurgitation. Become increasingly severe, you get symptomatic, and then it's time to do something about it. We mentioned this topic of mitral annular disjunction. Maybe Dr. Miller or Dr. Lorakis, can you walk us through what this means?
So basically, you know, because of the tension from the prolapse of the leaflets, you have basically disjunction. Basically, you know, the posterior leaflet detaches from the myocardium. I mean, not really detachment, but that's how it looks. So, and this has prognostic information for arrhythmia, and I think the longer it is, the more the chance of having arrhythmic mitral valve prolapse. And this also only seen in the posterior myocardium, in the posterior leaflet, because anteriorly you cannot see that because it's the aortomitral cortin, which is a fibrous tissue, so you cannot develop and see this aspect. So you see it, that's why you see it only posteriorly. And also you should measure this in edge systole. That's the time on the cycle of on the cycle that you should measure it.
So, and you can see here in this cohort, there is an association between mitral annular disjunction, independent association between that and increased arrhythmias, but not with excess mortality. As we mentioned before, we're not clearly seeing annular disjunction on this echo, but there was some calcification. Dr. Miller, when you just look at the pictures we've seen so far, does this seem like a smoking gun to explain these PVCs, or do we need more information?
Yeah, I mean, they're pretty common. She has the two most common types of PVCs that you see in mitral valve prolapse. The first most common being, which 60% of them are papillary muscle PVCs, and the second most common is outflow tract PVCs. So this would be consistent with someone who has prolapse or ventricular arrhythmias associated with mitral valve prolapse.
Okay. One other imaging sign we talk about a lot is the Pickelhaus sign, which, Dr. Miller, can you walk us through this? You were instrumental in discovering this.
That's an echo. I'll read echoes. But basically, Pickelhaus is just a manifestation. Obviously, other people can explain it better. But about 4 or 5 years ago, someone noticed that when you measure the tissue Dopplers of the lateral mitral annulus, if the velocities were high, then it was associated with the risk of ventricular arrhythmias. Again, it was a relatively small study. They expanded it to a larger patient population, and they validated it again. But ultimately, it's just probably a marker of traction, that there's more severe traction being placed on the papillary muscle and the cords.
Okay. On the tissue Doppler in this patient, I don't think that we see it clearly, although this wasn't measured kind of as clearly as it could have been in this outside hospital, but we don't see that peak above 16 centimeters per second in late systole there on the tissue Doppler. Okay,
Is
so
that-
yeah.
Is that maybe because there's also calcification there? In other words, is it like now become like a stiff?
Yes. It's gonna have some.
So at this point, we've got mitral valve prolapse, severe MR. We have PVC morphologies that would fit this sort of pathophysiology. At this point, is it time to get more imaging? When do we think about getting CT? When do we think about getting PET?
So just a couple of quick questions or points. In terms of mitral annular disjunction, has there been any data? The last time I had looked at it, it was about 8 millimeters. It sort of was a cutoff 8 to 10 millimeters, about a centimeter. Has that been expanded any further as far as prognosis is concerned, or at this stage, we are at this stage, the worse it is or the longer it is or the more disjointed it is, the worse the outcomes are? Does anybody know any more about that? Because when I looked at the data at the very beginning, it had said about 8 millimeters was the cutoff where we start seeing worsening outcomes. So I don't know if anybody has looked at that data.
I think in this, the main studies, the problem is that they're using like a binary for a lot of these studies, and they're just saying yes or no, there is mitral annular disjunction, which is why some studies show an association, others do not. I agree with you. I think that severity probably does matter. 8 millimeters or 6 millimeters, depending on what you look up, was kind of the cutoff of what's considered severe enough that there's an association. But I agree with you, because right now, the definition of most studies is 2 millimeters, which is, as we pointed out, 80% of the world has that. And so ultimately, they'll have to push that number out until it actually can discriminate those at risk versus those that are not at risk. But I agree with you, about 8 is usually what we start to get worried about.
Okay, so at this point, the patient gets a Holter monitor to look at their PVC burden. 27%, pretty high. Symptomatic with the palpitations. We're seeing couplets and triplets in those two morphologies that Dr. Miller mentioned. What do you need, Dr. Miller, to decide if you want to go in for an ablation? Do you need additional imaging here?
From an ablation standpoint, no. From an ablation standpoint, we would normally, with that high burden of PVCs, assuming that they didn't have severe MR, they just had kind of regular outflow tract PVCs and papillary muscle PVCs, symptoms plus a high burden is more than enough to offer catheter ablation. We very often do MRI, and we do MRI to look for structural heart disease. Whether or not it's actually necessary prior to ablation, probably not.
Dr. Miller, in terms of volume-wise, if there is severe MR or moderate to severe MR, as is the case over here, that makes a difference as to how the MR may be interpreted with regards to certain quantitative features like extracellular volume assessment and everything. So as an expert in this field, is that something that you pay a lot of attention to as far as echo volumes are concerned for LV quantification-wise, or is it something that does not matter when you're making the decision about cardiac MRI or not further down the line?
I don't think it really matters to us per se. I think from a MR standpoint, it maybe matters a little bit more, but from a purely electrophysiology standpoint, whether or not they have some LV dilatation or whether or not they have LV structural abnormalities doesn't really change our opinion whether or not to get rid of the PVCs. I think the bigger question that often comes up in this patient, we get multiple consults like this, is do you take care of the PVCs and then reassess the MR, Or do you just assume that the MR is severe and you'll try to take care of the PVCs either, during or after the mitral repair?
Well, this is a 73-year-old man. When do you worry about his coronaries? This is different than a 36-year-old woman. So 73-year-old
From the
man,
PVC
from the
perspective?
PVC
Yeah.
point of view.
I mean, I don't think there's any correlation between coronary disease and outflow tract PVCs or coronary disease and papillary muscle PVCs, unless the patient already had a prior infarct. But the thing I never understood was when patients have a high burden of PVCs on Holter monitor, the next test they get is a stress test. I've never understood that. These are not ischemic. This is all kind of delayed after depolarization. It's a triggered activity. It's not related to ischemia. But now, sometimes we'll do a coronary assessment because we want to give the patient isopril during a case. But we do it for that reason, but not for trying to work up the source of the PVCs.
And there certainly is LV dilation, which is attributed to the MR, but coronary disease potentially could be part of that as well. The patient did get a cardiac MRI, which I think was in part to try and quantify the mitral regurgitations, to show that there was a surgical indication, and also to look at the scar burden related to these PVCs. I'm not sure if you're involved in this yet, Dr. Miller. Maybe just by knowing where the morphology is, we can bypass the MRI. Oftentimes I know we get referrals for people with a lot of PVCs or NSVT just to find out where the scar is, but an EKG, if you're good at it, can show you the same thing. Dr. Agarwal, can you walk us through this MRI?
Sure. So again, for folks who have not looked at a lot of cardiac MRIs, you have your long axis views over here with the 2, 4, and 3 chambers. And what we saw on the echocardiogram, again, we are able to see that as far as the mitral valve prolapse is concerned, you see the dephasing mitral regurgitation jet. Just based on this, you cannot really quantify the severity of mitral regurgitation. What the other thing you can appreciate well over here is that the left ventricle looks a bit more dilated. I'm not sure how the body habit is, but it looks on the bigger side. You are again not seeing that mitral annular disjunction as well as was discussed on the echocardiogram. Again, you see the systolic curling that ends up happening. That's another feature that has been described with mitral valve prolapse. But you're not again able to see the mitral annular disjunction, the classic one where you're seeing the left atrium and the posterior mitral leaflet insertion and the left ventricular wall separating from each other, or at least the perceived separation, which you can see at end systole, as was mentioned by Dr. Larakis.
Could you speak to the quantification of mitral regurgitation by MR? Because that was essentially by MRI, because that essentially was the reason. More importantly, for what are the pitfalls in trying to use it?
So when it comes to mitral regurgitation assessment by cardiac MRI, you can do it by 2 methods. One is sort of a indirect method where you are doing LV volumetric assessment. So you go through, you do your Simpson's biplane assessment, and you are able to calculate your LV volumes. Then what we do is that we are able to calculate your stroke volume out or your forward flow across the aortic valve. And the difference between that, assuming everything else is okay, is your mitral regurgitant volume. The other is that you can try to place a region of interest around the mitral valve and see how much of regurgitation you're seeing across that directly, but that is a much more tedious method with a technically more difficult. Now, with everything else that is there, there are a lot of assumptions that go into this in terms of breath hold, free breathing, what are your volumetric changes, physiological changes that end up happening. You are making assumptions about the patient's heart rate being steady, there is no arrhythmias. As you can see over here on these cine images, the cine images are very, very blurry. This is not what a cardiac MRI generally looks like. And this is most likely because this patient was having high burden of ectopy at the time of getting the images also, which makes assessment of the mitral regurgitation in such patients challenging.
And this patient also had aortic regurgitation to increase.
Correct.
So it's, okay, thank you.
I'm pleased we have Dr. Yildiz joining us, imaging fellow from Mount Sinai West. Good morning, take over.
What would be the impact if you gave beta blocker and or other antiarrhythmic? Would you be happy to sort of say, okay, I adequately suppressed it? Is it
For the points of this imaging?
so I'm saying, so you have this patient, right, 73-year-old male, has 27% PVC burden, and, you say, okay, I'm gonna try beta blocker and, or another, and plus minus another antiarrhythmic, and I'm successful in suppressing it, or you don't think you'll achieve success with antiarrhythmic?
I personally don't believe that beta blockers or calcium channel blockers do anything to PVC burden. I think you get from like 14% to 11%, but they don't get rid of PVCs. Antiarrhythmics can have an effect, like flecainide or ruxolitinib definitely have some therapeutic effect. But ultimately, that's just a Band-Aid. And if the patient didn't have severe MR with that high burden of PVCs, I think most people would say this would be a class 1 indication for, catheter ablation for the PVCs. Ultimately, some patients decide they don't want a catheter ablation because they don't want an invasive procedure, and that's perfectly fine to try. But I don't think anyone's ever seen a patient who went from a high burden of PVCs to, very little PVCs with just beta blockers or calcium channel blockers. I think it's quite uncommon.
And when you say catheter ablation, which PVCs you would go after, both or?
Both. The goal would be, because obviously when patients leave the lab, we tell them, good news, we got rid of the dominant PVC, but you still have some residual PVCs from somewhere else. Ultimately, they just don't want any PVCs. And so usually what we'll do, depending on what's happening during the case, is we'll go after the one that's most frequent, address that one, and then move over to the other chamber to address the second one. And sometimes you're left with 3 or 4, and sometimes all you can do, especially if they have 4 or 5 morphologies, is get the burden down from 20% to 4%, and you consider that a victory. But in a situation like this where there's 2 PVCs, I think it's reasonable to go after both. You should be able to go after both.
One quick question from the imaging perspective. Do the cardiac MRI findings as far as the degree of fibrosis is concerned, let's say you're able to find that, or a degree of LG is concerned, does that make you change your decision as far as attempting catheter ablation versus trying an antiarrhythmic first? And if so, which antiarrhythmic is or is not off the board in that situation?
I think that the MRI, if they have a lot of structural heart disease and a lot of patchy scar, and they have multiple PVCs, it makes us less optimistic that we're going to be able to get rid of everything. If they have a focal area of scar and 1 or 2 morphologies, we're obviously much more optimistic. And sometimes we do use guidance from MRI to decide where the PVCs might be coming from. We think there's a general location and there's a focal replacement fibrosis in that area. It's likely from that source. But very often, it tells you don't do anything or yes, you can do something, but very little in between that.
So Dr. Agarwal, can you walk us through the short axis LGE here? In terms of what we're seeing.
So we have the short axis LG images over here. I think the left is probably a cine, if I'm not mistaken. And on the right side are your delayed gadolinium enhancement images at the same level. It is at the mid-ventricular level, as you can see from the papillary muscles. So as shown over here very nicely for all our reference, there is a big red arrow pointing towards a white spot. So I think the red arrow is not the issue, the white spot is the issue over here, because the white spot shows that there is a focus of late gadolinium enhancement that is affecting the infromedial papillary muscle, and where there is replacement fibrosis, as Dr. Miller was talking about, which is a pattern of late gadolinium enhancement that we often see in patients with mitral valve prolapse, especially if we go down the route of malignant or arrhythmic mitral valve prolapse.
Okay, great. So the patient goes for a PET scan, which is a little bit unusual. Was there any reason why this patient got a PET scan, Dr. Miller? Was it for research or for planning?
Technically, all these patients were enrolled in a research protocol. For this particular patient, I was curious to see why the patient, or if we could identify areas of activity in the outflow tract. Because we have lots of imaging done in patients with papillary muscle PVCs, and clearly there's concordance with scar and FDG uptake in the papillary muscles in those patients. But we were more curious about is this patient had such a high burden of outflow tract PVCs, which we thought, and I don't know if you're going to show the EKG, we thought were LVOT in origin. Could we identify some kind of inflammatory or FDG uptake in the LV outflow tract region? So it was a lot of academic curiosity, I would say.
And Dr. Agarwal, what's your interpretation of the PET scan here?
So essentially, this is a PET MRI where we are using the MRI for kind of placing the FDG images. So these are FDG images which are obtained after adequate preparation. So this is, I'm assuming the protocol will be pretty similar to what we do for inflammatory assessment. So FDG images are useful for assessment of myocardial inflammation. And to assess myocardial inflammation, we have to go through a period of preparation where the patient is given a 24-hour prolonged high fat, low carbohydrate preparation, and then they do an overnight fasting. And after that, the patient comes in. We need to make sure the blood sugars are adequately controlled. We inject them with FDG, and hopefully, if that preparation goes well, then you will see this sort of a pattern where the normal myocardium does not take up much FDG or very minimal FDG, and then the areas of inflammation inside the heart should light up. So over here, what you're seeing are two short axis views on the left side. One is at the very, very base of the left ventricle towards the mitral annulus, where you're seeing this one dense area of FDG, or dense focus of FDG, which is close to the anteroseptum, close to the outflow tract origin. And in the second image, you are seeing this dense focus again of FDG uptake in the infralateral wall towards the base to mid segments. And then the same things you are seeing on the long axis views as well, where you're seeing again that focus of FDG uptake at the basal septum.
So is that like technically sort of original subclinical myocarditis, or how do you interpret it?
So FDG uptake is any form of inflammation. So everything and anything that is there as far as any cause of myocardial inflammation is on the table at that point. So we have to place that in the clinical context. Can it be myocarditis, not necessarily chronic myocarditis, but more kind of a subacute or a sort of a picture, or you can have sarcoidosis, or as in this case, where there is this mitral valve prolapse with ongoing inflammation, then you can have this degree of FDG uptake. So I think there is a bigger teaching point in this beyond this case, to be honest, is that whenever you see FDG uptake on a cardiac PET scan, you have to put that in the correct clinical context and make sure everything else is making sense, because there can be a lot of different conditions which can be associated with FDG uptake, and you have to be careful about that. One of the other things that you have to be careful about is, in this case, it is not applicable, is when you have viability studies that are done, which is to assess if there is myocardial viability based on FDG assessment, they will actually look similar to this as far as the pattern is concerned, although the distribution and the LG findings will be different.
You know, to your point, and to Amit's point is, I think this whole idea of like the FDG and the PET scanning that's been done, and you know, there's recently a patient which they operated on who had presented somewhere else, also with PVCs. Someone did just a PET scan on them, and PET scan showed some FDG uptake. They, for some reason, diagnosed him with isolated cardiac sarcoidosis, started on steroids and methotrexate. And then he went to another doctor who noticed he had like prolapse with severe MR. And so then he got sent for a second opinion. It turns out that he just had one of these kind of findings, which is he had FDG uptake in the basal infralateral wall like you'd normally see, and no sarcoidosis whatsoever. And then he had severe MR with prolapse, and he got operated on, and all these immunosuppressants were stopped. So I think in the past, everyone who had a PET scan that was positive somehow got a conclusion, you know, consistent with sarcoidosis, and obviously that's not what this is. It has to be interpreted with a lot of caution.
Absolutely, and again, it is a very powerful tool. I think we in cardiology would have to be a bit more careful. Initially, about 7-8 years ago, when this field sort of like, started getting prominence, there was a lot of excitement about that when we didn't know any better. But as the technology is being adopted more, and we are beginning to find out that this is not just sarcoidosis or cardiac sarcoidosis, but there are other conditions also, I think we have to always place it in the clinical context. So go back, look at the patient history, try to get as much information as you can. Quite often what ends up happening is that if the PET scans sometimes can be done at centers who do not have access to the echo data at that point when they're interpreting it. And then it comes down, unfortunately, on the shoulders of the person who's ordering it to put the whole clinical context in picture. If there is suspicion of sarcoidosis, if there is extracardiac sarcoid and everything, then that puts probably greater emphasis on it being cardiac sarcoidosis. But then in other conditions like this one, as Dr. Miller said, you always have to place it in clinical context.
Yeah, just a quick question, Dr. Agarwal. We like to think of arrhythmia sequences on MRI as being able to detect inflammation, on the HASTE and T2 weighted images. So, is there a correlation between looking at, edema sequences on traditional MRI and FDG uptake on on this co-registered MRI, when you have arrhythmogenic mitral prolapse with contraction that we discussed before.
So that's a very good question, to be honest, and I think it kind of leads to a more fundamental discussion about edema assessment or acute inflammation assessment on cardiac MRI. When we look at inflammation or edema, acute inflammation or myocardial edema, we are always trying to compare it to the surrounding tissue. And it depends upon how much nulling or fat suppression you're getting on your black blood imaging that you're talking about. And if you do not have adequate suppression, then those images can be very, very tough to interpret. Quite often you have these areas, but like you see there may be some edema that may be present, but that gets affected a lot by cardiac motion, all the other things. The other thing that ends up happening just in the field of cardiac MRI is that because of the challenges that were associated with visual assessment of myocardial edema, T2 mapping came about. And T2 mapping is a more quantitative assessment as opposed to just focusing on visual assessment and trying to come up with numbers as opposed to just your eyes, what they are telling you. But again, in that, centers have different cutoffs. What a patient may have in one region versus the other, that becomes challenging. So from my personal perspective, you see edema on a cardiac MRI, that is concerning. But quite often you miss edema on cardiac MRIs, which is picked up much better on cardiac PET scans on a day-to-day basis. Now again, there may be some exceptional centers which do a very, very good job with good sequences on cardiac MRI, but for most bread and butter purposes, I think cardiac MRI can miss inflammation, acute inflammation, which can be picked up on cardiac PET scan.
So I think it depends on the size, you know, I mean, it depends on the size of the edema, or, I mean, if you have diffuse edema, of course you pick it up. If it's like something like this, I think it would be difficult to pick up with MRI, something like this.
Correct.
So, you know, it's nice to have a single unifying diagnosis to explain all of our imaging findings. And if you go forward, I think one more slide maybe. Right, so classically when we think about arrhythmic MVP, we think about seeing inflammation in that infralateral wall in that posterior medial papillary muscle. And we are seeing that on this patient, but we're also seeing inflammation kind of in the LV summit on that basal anterior wall. Is that something that can be seen with arrhythmic mitral prolapse, maybe a bileaflet prolapse, or do we have another explanation?
Me?
The panel.
I mean, I think, so we didn't show the EKG, but what was interesting about the EKG
You can go ahead too, just like
is what's interesting about the dominant PVC morphology and the 12, there you go, the 12 lead. You notice how like you have V1 is left bundle, and then all of a sudden at V3 it becomes positive in that PVC. So that's called an abrupt V3 transition. And it's pretty classic for an area of the LVOT called the interleaflet triangle. So normally when we're ablating in the PVC from the LVOT, we go retrograde, we land in the cusps, we map around, and then we ablate in the cusps. But right under the cusps in the myocardium is this little triangle of tissue. There it is, the interleaflet triangle, which is classically been associated with this, what's called abrupt V3 transition. It usually comes. So what you do is you take your catheter, and because most PVCs come from a transition zone in the outflow tract between the fibrotic tissue of the outflow tract and the myocardium, is you bring your catheter right under the valve, you hook it under there, and usually that's where the PVC is located. So this area right here, I would imagine, is exposed to the same stressors as the mitral annulus is in someone with prolapse and severe MR, because to me, this is all part of the same structure. Like for example, the AMC is part of the structure too. So it's not surprising that they'd have abnormal tissue characteristics in this location, the LVOT, and I discussed during the grand rounds, most patients with outflow tract PVCs and mitral valve prolapse tend to be the LVOT as opposed to the RVOT, but in the rest of the world, RVOT is the most common. So to me, it makes sense. What we didn't know is we could identify areas of abnormal myocardial metabolism or activity in this particular location. And I think if you go back to the slide beforehand, one more back. So, the way I look at this is kind of the LV summit area. So I just put together this little figure of where the aorta is, where we would traditionally put our catheter. We put it through the leaflets, and then we would hook the catheter right under the valve. And where that catheter is located is that interleaflet triangle. And so what's interesting is in this particular patient, clearly the PET MRI is lighting up in this location where we thought the PVCs were coming from before we did the imaging. And you asked earlier why we did the imaging. One of the reasons is because if we're going to take a slightly different approach than we've ever taken before, or they're going to take a different approach during surgery, I wanted some kind of additional information to prove that the area that was going to be addressed was a clinically relevant area.
Okay, so at this point, are we ready to go to surgery? And how did you think about how you were going to do it? It was a multidisciplinary approach.
Remember, the arrhythmias is not included in the guidelines for indication for mitral surgery. It's all about symptoms, LV remodeling, EF dimensions, or complication like AFib, pulmonary hypertension, etc. So it's in the back of our mind that this could be a collateral benefit from surgery, as we all know that, but the primary indication was class 1 indication because of enhancement and symptoms. This is all, a lot of interesting imaging, which we spoke about with Mark and our team, and that ultimately impacted the management of this patient. But if you go by the guidelines, we know that the patient has a class 1 indication, he needs mitral repair, plus or minus any other adjunctive measures that you can do off-label, and basically that's out of the clinical context of that. It's more of a research interest.
But I think to the credit of the surgeons, most surgical centers in the country would basically say, we're going to fix your valve, and then afterwards you can go meet with whatever electrophysiologist or cardiologist you want and take care of the PVCs. It's rare, I think, you'll find a situation where they're willing to take their time and effort to combine both essentially independent procedures into one procedure for the patient. I think that's what makes the surgical group here at Sinai quite unique.
When you have 27% PVC burden, you're going to cause some LV dysfunction, right, above 12% or 10%. So another approach could have been ablation and then reassess the ventricle and the mitral regurgitation, correct?
Yeah, but remember the high burden of people, the minority of people, that is true, and some patients have taken that approach. But the minority of people who have a high PVC burden actually develop LV dysfunction. It's maybe 10% of people who have a PVC burden more than 15% ever develop LV dysfunction. So you're certainly correct. You could have done that. You still probably would have ended up with severe MR anyways, and the patient ultimately would have gone for surgery anyways. But people have done that before, where you've gotten rid of the PVCs and then reassess. It's certainly an approach.
And I think the patient has the anatomic culprit for primary mitral disease, severe MR, manic, etc. So I think it's far more deep into the clinical presentation versus patients who you see with no or mild MR and some prolapse and the same arrhythmogenic picture, which is a subgroup of these patients.
But on the basis, so you're going from a 2A, 2B to a 1A on the basis of saying symptoms mitral prolapse. But there's the possibility that the symptoms are related to the 27% burden, and then that would change, So again, as Mark said, this is such a unique institution that we can give one-stop shopping and cure the patient. But I'm saying that I think thinking about the patient, it's a 73-year-old patient. We haven't looked at the coronaries yet. We haven't, could that have been an option? Because 27%, 1 out of 4, and that could have caused some papillary muscle dysfunction on a chronic basis and may have exacerbated the MR. This patient doesn't have the mitral annular disjunction, and though it has the inflammatory markers, I guess we would say that this patient has had chronic prolapse, and that's what's caused the inflammation, and the inflammation helped to potentiate the calcification on the papillary muscle, at the base of the papillary muscle at the annulus. So that may have been around for a long time. That's why the left atrium is dilated and stuff like that. So just thinking broadly about the patient, this is more complex, because of the arrhythmia, because of the potential LV dysfunction that be caused by that higher burden of PVC.
So hypothetically, since this patient's MR was more on the moderate to severe side, the surgical decision was made based on that, considering the symptoms as well. Let's say this patient had more mild MR. Then what would have been the approach in that situation? Because then surgery probably would have been off the table in that sort of a situation.
We've seen those patients. We just saw a patient like that, I think a week or two ago, who saw them for mild to moderate MR and a high burden of PVCs, and they told the patient, you don't need surgery, take care of the PVCs and then reassess. I think when it's on either extreme, it's a relatively straightforward decision. It's when it's in that middle zone that sometimes it's more difficult.
So now can you walk us through what was done intraoperatively? I think we have a video we can show.
Yeah, we can show the video, I think, straight. So the patient, I mean, basically had a, can you go back one slide just to give an overview of this before we go to the imaging? So we did repair the valve, a quadrangular resection, and I should say this, quadrangular resection, you cut the big piece of P2, you slide the annulus, and that will correct the mitral annular disjunction if you have one. And then, of course, the ring annular plus the tricuspid. And then, as the recommendation was to ablate the papillary muscle, if we can localize it. So I think we know that this patient had posterior papillary muscle morphology, PVCs, and we went after the LV summit, which I personally never heard about that term until Mark told us where to find it. I mean, we opened the aortic valve every day.
It's never been done intraoperative, right?
Yeah, we open the aortic valve, the aortic, we expose the aortic valve, we look at these subcommissural triangles and stuff. But I never known that it's called the LV summit particularly. So you can go to the video then.
So before we get to the video, because we went back and forth for a while, because in catheter ablation, sometimes you can't ablate it from underneath because the tissue is so thick.
Stop the video, sir.
You can't ablate it because the tissue is so thick. And there are people out there who've actually gone to epicardial procedures, like robotic epicardial electrophysiologists, to get it from the epicardial surface. The problem with the epicardial surface, even though they have easy access to it, is that the left main and the LAD are sitting right there, right at the LV summit. So nobody's willing to, especially in coronaries that are not flowing with blood essentially, to perform ablation on the epicardial surface so close. So the only option was to go under the valve. The problem is that from a surgical perspective, that's not normally an area that's accessible. So they had a long conversation with the patient about the off-label kind of surgical approach here, which the patient was very much into that idea and actually signed all the consents for it. And then he'll explain the video. So this is the aortic view.
So this is the aortic view. So this patient had to open the aorta so we can access the LV summit. So you can see the leaflet on the front is the right coronary cusp, and then this is the left coronary cusp. So this is a subcommissural triangle between, and we marked it with ink here. Then we applied this cryo probe that we use, as you know, for AFib ablations or any kind of intracardiac ablation. And we did touch that area specifically without touching any surrounding structure. You can use, you have this adhesive stability of the cryo. You can create a very deep, diffuse lesion here. So we know that this area should be ablated at this point very well, with the cryoablation, which is an advantage of surgical cryoablation. So we close the aorta and then we turn our attention to the mitral valve. You can go to the next video, I think, or the next picture. You can see this is the anterior papillary muscle, so we use the same probe to do a very deep transmural, again, line. Usually do 3 minutes twice, as we do for atrial ablations, and that will give you almost like transmural ablation of the papillary muscle. As we know, we ablate the mitral valve inadvertently all the time when we do AFib ablation because we have to cross the mitral annulus to get the coronary sinus. And in our experience, it has never been shown to be a problem for the mitral leaflet itself. So that's why we were sort of encouraged to try to do this papillary ablation because it will take the papillary muscle, the cords, and sometimes the mitral leaflet on the way. But I think, Mark, we published almost a small case series, which was unique because this hasn't been done before, intraoperative, as opposed to preoperative. And you can see the advantage of intraoperative ablation versus catheter-based ablation. You have a bloodless field. You can directly apply the probe where you want. You have the advantages of using cryoablation. And you can have more effective sort of diffused ablation than PVC or catheter-guided ablation will give you. Maybe Mark can comment on
I think one of the comments we get, because we get a lot of consults for adjunctive intraoperative ablation, and our general criteria here is that if they have a high burden of focal PVCs, for example, let's say 15 or 20% of papillary muscle PVCs in which we have at least 2 pieces of information, EKG, which is suggestive of, and imaging, which is also suggestive of a specific location. Because what we don't want to do is say it's roughly the papillary muscle, and therefore we're going to do ablation because we don't know the long-term safety of this approach. So usually if they have to have those two criteria, or if they have very clear PVCs that are inducing malignant ventricular arrhythmias, like papillary muscle PVC is a low burden, but they're inducing, let's say, VF. That's the other patient population we would do it in. But again, you have to have other adjunctive information from imaging to suggest that that's the location involved. What you don't want to do, and you don't want to start happening, is people just say, well, it kind of looks like the papillary muscle and there's 5%, so let's just go ahead and do adjunctive ablation, because we don't know the long-term effects of this. So we probably say no ablation in 95% of cases we get consulted on, and 5% we actually say yes, because we have enough information to do what is essentially an empiric off-label adjunctive procedure.
Especially if we know that the morbidity of the procedure, even if it's not successful, is very low. Yeah. Like this, it takes 3 minutes, it doesn't have any ischemic time, and we know the technology is safe. Yeah.
How much based on, sorry, so if you can just pursue what you're both saying, because if you do it when the patient is not in surgery, not on bypass, you can actually, you have beating heart, you can see and map it. Right here, you're going, sort of a little bit blindly because it's the flaccid heart, and you don't know potentially, what damage you could do. So is it a better approach to do it, as a staged procedure rather than doing an ablation at the time of surgery?
In most cases, yes. I mean, in most cases, we don't recommend ablation. But there are definitely patient populations where they have a high enough burden that we are relatively sure that we know exactly where it's coming from, that you can do an empiric ablation. But the vast majority of patients, we recommend catheter ablation. But remember, catheter ablation, as good as it is for papillary muscle, the actual published success rate is only 60%, because you're using a 4mm catheter on a moving heart in a blood field. And instead of coming from where you can ablate from the tip of the papillary muscle, but in reality it's coming from the base of the papillary muscle and you can't get your energy down there. The lesions they apply are much more effective when there's no blood and it's a large cryoprobe. But again, you have to use it very judiciously. They do 500 surgeries here a year, of which 50% have PVCs at least, and we maybe do, one every few months where we actually do an adjunctive intraoperative ablation. So I think it is used quite infrequently.
Mark, is there any role for EP study when surgical approach will be taken just to gather any additional information, or there is no role in such situations?
I think it would be great. The problem, the answer is yes, but that has its own small risks associated with the procedure. It's the second procedure. A lot of patients don't want to go through a percutaneous mapping procedure prior to their planned open heart surgery. They're just mentally not ready for that. And also, what's the chances that we put a catheter in a map and don't turn on the energy? So I don't think we can control ourselves.
We'll tie your hands.
So people have talked about it, like doing preoperative mapping, but if you're already going to do that and you're using the same catheters, you might as well apply the ablation. But a lot of patients are like, I'm going to have my surgery, that's what I want, and I don't want to have any procedures before that that's going to impede me getting to that surgery.
And the question is, why not to just do the surgery and forget this ablation and see how it goes? And then if you need ablation, you can always come back for it.
I don't believe that. I think that mitral valve surgery reduces the complexity of your ventricular arrhythmias, and I think it makes you less likely to die of sudden death. I think it has almost zero impact on PVC burden. If you have high burden of PVCs, and in years past, I think when patients came to the office 5 years ago, the surgeons always said, don't worry, we're gonna fix the valve and the PVCs will get better. And in general, they never really got better, meaning the PVC burden didn't go down. So I think nowadays we have a clear understanding that it has a very modest effect in a very small percentage of the patients. And so addressing them as an issue, preoperatively, intraoperatively, postoperatively, I think is relative to the patient.
On this patient who had the delayed enhancement on the papillary muscle, did you see it? What did you find when you open up?
Well, sometimes you see scarring, like if you look at the left, even sometimes you can see the scar on the papillary muscle, on the endocardium, which looks distinct from the surrounding endocardium areas.
That's what you ablate, or?
We ablated the whole because as Mark said, it could be apex, could be the base of the muscle. So we do the transmural lesion across the longitudinal axis of the whole patellary muscle. So we ablated areas where this scar where PVC coming from, and we also ablated other areas that did not contribute probably to it. But because that's just the limitations of surgery, we don't just touch the area where the PVCs comes from.
Yeah, I asked that question a couple of years ago during, like, when I went down there, can you see scar? And I think the surgeons have always noticed the scar. No one's actually described it, even in a manuscript, as far as I know, is what are the visual characteristics of patients who have delayed enhancement on the papillary muscle that you see at the time of surgery. I think the surgeons did the surgery. They noticed that there was some fibrotic tissue in the papillary muscle, but no one really actually correlated, that necessarily the two are related or is related to ventricular arrhythmias. So, but the surgeons do say that they see scar tissue, at least on the papillary muscle.
We see scars all the time in coronary surgery because you can see the myocardium right in front of you. We are not used to seeing like endocavitary scars. That's sort of unusual.
Because you're not looking, or like, in other words, like it's just
Because
not part of.
we don't necessarily operate inside the ventricle,
Right.
Most of the surgeries are either epicardial or valves. I guess the only people who explore that in coronary surgery, in aneurysms and patient had like apical scars and then maybe ablation. This is like sort of another area of
So I think now
cardiac
that,
surgery.
now that you're
which we
putting the
don't see.
camera into the ventricle,
Yeah.
you're noticing more.
Exactly.
So how do our patients do post-op?
These are the postoperative echocardiographies.
Yeah, basically, the MR is gone.
You didn't hear the atrial fibrillation work.
No, this might be post-operative.
Great result.
Hmm?
Great result.
Thank you. What about the arrhythmias?
Arrhythmias also decreased. So the burden of arrhythmia decreased to 2%, which was 27% before the surgery. And based on this, the medications were adjusted after that. And on the follow-up around 1 year after the surgery, around 15 months after surgery, she was doing well, no active complaints. The exam was normal, the murmur was gone, and everything was good. The only thing is upper normal blood pressure values there. She was added losartan 25 milligrams in addition to metoprolol and aspirin daily, and she was doing well with these medications without any complaints.
Just go over the timing. So how long was the person on amnio? Just for the 5 days intraoperatively for the AFib?
So she was put on the amnio for the AFib because she had post-op AFib, which resolved at some point. And then I took it all off. Then we did a monitor, then we did another follow-up monitor. But I think it was like maybe like 2 weeks or so that she was actually on amnio.
Quick question. So I think a great case. I mean, spectacular result. The question I had was similar to the comment about the myocardial scar. I think the fibrosis on MRI is pretty well. We have good correlation with pathologic data to see what that represents. Was there any thought to biopsying those areas that you ablated? Because there was some ambiguity of what the FDG potentially could represent, and some ambiguity about Saul said about what the edema might represent on the various imaging sequences. Was there a thought of maybe trying to see pathologically what those areas are that before you ablate those areas?
So that's one of the cohorts of the current study, is for patients that undergo hybrid PET MRI imaging, who then undergo surgery, they will biopsy the myocardium or the papillary muscle to demonstrate that there's areas of fibrosis as well as macrophage activity in those locations, so we can finally make that histological correlation with the imaging correlation. As far as I know, no one has done that as of yet. They've done it in surgical patients who got regular MRIs, and they showed, yes, there's scar there, but they haven't taken the next step, which is the goal of one of the cohorts that they're doing for the study.
Why?
Any other questions from the audience?
So Mark, I know you have this NIH now grant. So what is the flow like? If somebody has like a patient with mitral prolapse,
Thank you
they
for asking.
refer to you like what?
So
what is the-
basically, if all you need to enroll, there's two cohorts. One is the patients going for surgery of severe MR, let's say the severe MR group, and then the non-severe MR group. Non-severe MR group, which is what we deal with, is basically if you have true prolapse with any degree of MR, even no MR, and you have any history of PVCs. So if you have, and again, we don't want necessarily patients with lots of PVCs or lots of ventricular ectopy because we need to compare to a cohort with less. And so if you have even a history of PVCs or a PVC and EKG, you can enroll, then it's a 5-year study. We do hybrid PET MRI imaging over the course of 5 years. Every year they get a monitor, every year they get obviously a phone call visit, every year they get a 3D echo. So we're gonna follow them over 5 years to see does the ventricular arrhythmia burden and severity change with time? How does the imaging characteristics change with time in patients depending on their ventricular arrhythmia burden? And then for the surgical group, what they're doing is they're also doing twice imaging before surgery, and then a year or two after surgery